Hi there everyone and welcome to today's VR lesson. Today's lesson's on the kidney. Today we're using our patient as a muse and we're looking at their left kidney. So let's just start having a look at the anatomy of the left kidney. So the kidney actually lies in a V-shaped lie, the right and the left. Now patient, I need a big breath in from you. Hold your breath there, and as we can see here, we're seeing the kidney actually quite nicely. Let me zoom that up for you there. Okay, breathe away, patient. Now, what we're seeing here with our pointer, as you can see, is our outer capsule. So we've got our renal capsule and we've got our perinephric fat around the kidney, which protects the kidney. Then we've got the carotid fascia that outlines the kidney here also. Now this is slightly indistinguishable on ultrasound and you probably won't see the difference between the carotid fascia, but you will see the perinephric fat. Now we're seeing the cortex here. Now this has a similar appearance to the splenic tissue. Now on the other side, when we're looking at our right kidney, the right kidney should look slightly less hypoechoic than the liver. Now the kidney and the liver actually has a similar echo texture. Now moving on, what we're seeing here is the medulla. So the medulla actually demonstrates, see if we can see them, big breath in there. The medulla actually demonstrates our pyramids. Now pyramids aren't as obvious in the adult patient. We can actually see some of our triangular pyramids here on our adult patient. However, in children, it's a lot more noticeable. Now, moving on to our anatomy, big breath in. What we're seeing here is our sinus, and we can see our echogenic sinus here where our filtration is actually going to occur. Now, within our pyramids, I know it's difficult to appreciate our pyramids here. However, we have our pyramids, they're our triangular shaped structures, and then they go down into a beak shape called our papilla. So they're our papillary junction of our pyramids. So here, the outer margin is our cortex. Now, our cortex should be at least 1 centimetre thick. So we're measuring this and it's 1.5 centimetre. Now, in those people with kidney problems, renal failure, we need to measure the cortical margin and it should be over 10 millimetres. If you see a kidney with a thin cortical margin, you need to investigate this for renal problems or renal failure. Big breath in, patient. Okay, now looking at our kidney here, we're seeing the spleen overlying the top. I'm just going to optimise that kidney so that you can see that a bit better. Now, when we're doing kidney measurements, our kidneys, our right and left kidneys, should only vary by 2 centimetres. So 2 centimetre difference in some texts and a 1 centimetre difference in others between the right and the left kidney. Now take a big breath in there for me. Now if you can also take note of my hand placement and where my hand is and how it's laying on the abdomen of the patient, and you can see the lie of that left kidney. It's in a V-shaped orientation. Now when performing our measurements, we actually like to get the uppermost length of the upper pole and we'll measure down to the maximum distance of our lower pole. Now this kidney is measuring 9.45 centimetres, which is very average for an adult male. So when we're measuring kidneys, they should measure anywhere between 10 to 12 centimetres and depending on the person's bodily habitus and their size. So the larger the male, kidneys can actually get up to 15 centimetres, particularly in those patients with a duplex kidney. Now a duplex kidney, if we were to see a duplex kidney, big breath in there, patient. This patient hasn't got a duplex collecting system, but what we would see is this sinus region separated by a line of black. So this is called a column of Burton or a duplex system where the kidney has actually separated and got 2 different collecting systems. So we're not seeing that in this patient and its measurements are acceptable. However, just know in a duplex system, you can get extra long and lengthy kidneys. Now moving back to our anatomy, just big breath in there for me, patient. What we're seeing here is we've done the inside to outside. We're just going to put an overlay of colour on this kidney. So we have to turn down our 2D because it's inversely proportional to our colour. And then we're just turning our colour right up there And we're just going to freeze that in a moment. This poor patient is doing really well. Okay, so we've frozen our blood flow there. So we've actually initiated a colour Doppler overlay. So this is using the Doppler equation. Now, in kidneys, what we have are our 5 segmental arteries. So we have our renal artery feeding into our kidney, separating into our 5 segmental arteries. Therefore, then they come off into our interlobar arteries. So they go in between the lobes. Then they follow our arcuate arteries, which go around and follow the cortex of the outer capsule. So the arcuate, and then we go into our interlobular and also our cortical radiate margins. We'll see if we can get a better colour flow there. Big breath in for me. Now, if you're not sure, which you probably should be, the difference between the red and the blue, as we can see here using our snake eyes or our scale, so black is 0 Doppler shift, red means the Doppler shift is towards the probe, towards the top of the probe, blue means going away. So red is moving towards the probe, blue is moving away, and this is our renal vasculature supply. Okay, so we're just going to uninitiate our colour. Okay, big breath in for me, patient. Okay, so we're getting an overlay of a power Doppler angiogram, and what we're seeing is the power is actually measuring the velocity, so it's non-directional. Power is actually more sensitive to picking up vasculature supply within the kidney. So let's just have another look at the kidney. Big breath in for me, patient. Let's have a look at the surroundings of our left kidney or our relational anatomy. So what we're seeing here is the spleen, and quite often when we're scanning, we can actually compare the size of the spleen to the kidney. Now, if we have an overriding spleen, which means it goes further than half of the kidney, we know that there's obvious splenomegaly involved. So this is the spleen is enlarged. Now, a general sizing of a spleen is up to 12 to 15 centimetres, once again depending on the size of the patient. And it should be a nice homogeneous texture, echo texture, similar to that of the liver. So this is a very important technique when you're scanning your left kidney and your spleen. So big breath in there, patient. Once again, another issue with the spleen is bowel. Because we have the stomach, so the stomach sits up here, and it might not be obvious, but we can see all this bowel matter here, and we can see what's known as dirty shadowing. So this dirty shadowing is an acoustic artifact, and it causes issues because it shadows over our renal tissue. So big breath in again. That's it, thanks patient. And we can see our left kidney here sitting nicely. Now, there are many windows that you can use for renal scanning. First of all, we can use our anterior window, and I'll show you that. Big breath in, patient. So our anterior window, which isn't very successful because there's bowel gas there, or we can use our coronal window for our left kidney, so we can see our coronal window, or our posterior window coming through the back muscles. So big breath in again. That's it, patient. So if you're not seeing your kidney too clearly, you may need to choose just a different window, and you may need to also reposition your patient. So we're using a posterior window. Quite often these 3 windows are used, particularly with the right kidney. The left, generally, with the left kidney, it generally works to be in a decubitus position or a posterior oblique position. Now, the preset that we are using here is an abdorenal preset, and the patient, there's no need to really fast the patient unless you're getting excessive bowel gas. Now, the patient must be well hydrated, as in cases of dehydrated kidneys, they can appear quite shrunken and quite echogenic, so it's very important that your patient is hydrated. You could also ask the patient to fast if there are issues with bowel gas. Also abstain from drinking milk, dairy products, smoking, and no chewing gum. So big breath in again, patient. That's it. So we'll just have another look at that kidney. So we can see the kidney here. We can play with our physics called our compression. So that actually affects the dynamic range. We can increase and decrease our sector width. Now that will give us more lines of sight. So therefore we will get a better image of our kidney in these different cases. And also you can change your preset. So we can go to Urology General, we can change a different preset, and these IU22 machines all should have specific presets, particularly when you're dealing with a diseased kidney. Now, the different pathologies that you may be looking for include nephrocalcinosis, so stones of the kidney. We may also be looking for a hydronephrosis, so some sort of occlusion. So this may be caused by stones actually coming down, embedding, getting stuck in the ureter. So we'll actually go into a transverse image here. So we're in a longitudinal plane here, turning 90 degrees and decreasing our sector width, and we can see a nice kidney here, and we can do a plane sweep all the way through the kidney, and always make sure you look all the way right to the top, because remember our adrenal glands actually sit on top of our kidney. Breathe away, patient. Now big breath in again for me. That's it. And here quite often we will use the spleen as a nice acoustic window just to remove that bowel gas away from the kidney. So having a look all the way through, getting a bit of rib shadow there, and coming back to a mid portion of that renal hilus. So here we have a transverse image of our kidney, and we can see our cortex, our sinus, and our pyramids, the papilla. Now, one thing that we probably can't see too well is the major calyces and the minor calyces. Big breath in. So that's all involved generally in our collecting system. Big breath in now. Now, when scanning the kidney, what we need to be mindful of is the embryology that occurs in its development. Now, the kidney is actually made up from pronephrons, mesonephrons and metanephrons, which are three different ureteric buds which all fuse, and then they ascend from the pelvis. So sometimes if you're in the renal bed and you're not actually finding a kidney, it pays to follow the ureter down and have a look at different places, particularly in the pelvis. So quite often I've performed a scan and we've found a pelvic kidney, or there's actually been a genesis of the kidney, so the kidney hasn't developed. Now, there's many congenital anomalies with the kidney. There may be a malrotated kidney, so it's not sitting in its correct axis or plane. The collecting system sometimes will be exposed out in the junction here, so an exposed collecting system. Now, looking at the pathologies of the kidney, so this kidney is actually quite normal in stature and isn't infiltrated by any disease process. But there are many, many different types of disease processes that can actually occur with the kidney, including different types of cysts. So we can have different types of cysts, such as cortical cysts. We can have hemorrhagic cysts, so there's blood. You may see them extraphytic cysts, so they're out in the cortex. You can see hemorrhagic, so there may be blood in there, so you may have to turn your patient around to see that the material within the cyst actually moves. There can be septated cysts, or you can get these junctional parenchymal cysts seen down infiltrating in the sinus. Now, they're a different shape. They're actually more teardrop shaped when you're seeing these junctional parenchymal cysts, as opposed to your cortical cyst, which is seen out in the periphery. Now, a simple cyst is defined by a clear fluid, so it's usually hypoechoic, and the ultrasound speeds up when it travels through the cyst. So there is an artifact called a posterior acoustic enhancement, which actually occurs behind the cyst. So this is a giveaway that this type of pathology is actually fluid filled. Now, when we're looking at a more sinister pathology, such as a renal cell carcinoma, now it will be more typically the echotexture of the kidney. Now, renal cell carcinomas, they tend to have a male prevalence and usually are found in adults over the age of 50. So when you see an RCC, this is the most important and main pathology that you'll see when scanning a kidney in an older person or in an adult. So generally they are echogenic, they can be hypoechoic, and you'll see a mass. And sometimes they're not that obvious, so sometimes it's important that you turn down your dynamic range and investigate that renal cell carcinoma. Now, there are other pathologies, particularly in children, such as Wilms tumours, nephroblastomas. Just be alert, no normal, and anything that varies from normal, you need to investigate, you need to activate your Doppler, and always measure in 3 different planes. There's other types of pathology. There's many types of pathology, such as medullary sponge kidney. You'll see different calcifications throughout the kidney. Angiomyolipomas, which are echogenic benign masses that you may see in the cortical region. So angiomyolipomas, this will be an everyday occurrence for you in your scanning career. And also, if we have a big breath in there patient, sometimes you can see an artefact or a congenital anomaly, and it can be mistaken for scarring, so scarring of the kidney. Now, this artefact or breathe away anomaly is generally found in the right kidney, not in the left. This is the left kidney, at this junction. So this is a right parenchymal junctional defect. So generally it sits in and indents here in the right kidney. Now, this is quite often mistaken for a scar. However, it's not. It's actually where the upper bud and the lower bud of the kidney fuse. So just be aware of that in your right kidney. Now, other everyday occurrences that you'll see is hydronephrosis. So whether there's an obstruction by a calculus, so the ureter can actually get obstructed by calculi made of calcium oxalate. So therefore, what we need to do as sonographers is big breath in, thanks. We need to reduce our focus. We need to put our focus right on where the pathology is, and what we'll see is if there's a stone, it will actually cause an acoustic shadow. So this shadow should be nice and sharp depending on the composition of the stone, and what it might actually be occurring is hydronephrosis of the kidney. Now, there's many different grades. There's 4 different gradings of hydronephrosis, and it depends how much it's actually obstructing the collecting system. So what you'll see here, instead of this nice white sinus, you'll see the calyces, the major and the minor calyces, expanded, and sometimes to the extent of clubbing. So our job is to extend our study and try and find out where that obstruction is occurring. So that's all we'll talk about today. Thank you very much for joining me. Thank you.